Hello, everybody. How's everybody doing?
Good.
Yeah, you're making it through Thursday of New York Tech Week, so you're still here. That's good. Who watched the Knicks last night? All right. Exactly. I knew I'd get a couple. Well, great. I've come from a background, 25 years, working in fintech and smart cities and biotech, and there was always a tech-enabled or a big data-enabled product involved. So when I got to better know Alopex, it was exciting because of the amount of data they had, but also the opportunity to really reestablish a AI native platform. So as I'm sure you're all aware, AI and healthcare, I don't think there's a session that has healthcare without AI in it this week, so we're definitely going to get into that. So with me today, we have a couple of great folks who are going to help us through. To my immediate right here, we have Stephen Kelly, who is leads business performance and value creation at Cityblock Health. Cityblock is a New York City founded healthcare company back in the teens, right? 2017. And they were built specifically to serve low-income, medically complex communities, primarily those who are, duly eligible and on Medicaid, which is very unique. So looking forward to hearing more about that. To his right, we have Dave Bliss, who is the SVP of Alopex. And Dave leads their commercial efforts, and he's had a full career in virtual care, remote care programs. So we're going to hear a lot about how he views closing the care gaps, and now with technology. And then last but not least, at the end, we have Joe Honcz, who, as he likes to describe himself, he's a recovering payer. So he's turned into a market access leader. So he's going to bring that perspective on, how the payers view things, but he's also working and consulting with a lot of companies to help them understand, what their strategic direction should be as it relates to this. So with that, I'm going to jump in. The first segment, we'll talk about closing the care gap. So with that, Dave, when you look at patients that Alopex is serving, they have complex chronic conditions. They have very fragmented care histories. We use this term, closing the care gap. What does that actually mean in practice? And then, what does intervention into those patients' lives look like?
Thanks, Rich. Hello, everybody. So at Alopex, the way that we view closing care gaps is going from information to intervention, right? So using technology to surface insights so that our clinical teams can interact with patients that are enrolled in our services in order to produce a less costly outcome or to keep them more healthy for a longer period of time. So essentially using technology to comb the medical record, surface insights, give our care coordinators the ability to reach out and have a good dialogue with a provider. So that's one area that we use technology, right? When we can do that effectively, we can kind of manage the outcome for the patient and for the vendor, the client that we're working with at the time. Technology is a key driver in what we do today to drive those particular outcomes, and it's evidenced in the fact that when we can build trust and rapport with a client, we can produce outcomes that are attractive in the marketplace. Example is, we have about a 5% 30-day readmission rate for people that are enrolled in our program, hospital readmissions. So being able to develop rapport, communicate with the provider, produce data and documentation that's auditable and defensible and reliable is critical to what we do when we produce those outcomes. So that's what closing care gaps is for us.
You mentioned the 5% 30-day readmissions. Is there something in particular that drives that number down? I mean, that's always been I think a metric that virtual care companies have focused on. So is there obvious data there?
Yeah, there's absolute obvious data there, right? But I think what it is it's getting the data in a timely manner and having it surfaced, those signals, so that you can intervene and being able to interact on the little things. So being involved in the little things and having the technology to identify those and drive efficiency for our team so that we can be pointed when we do have those interventions with patients.
Great. And Joe, from a payer's perspective, the clinical improvements that Dave was just mentioning, how do those show up in the data, or do the payers care about? I know they care about it, but how closely are they looking at that? How much value do they see?
We really care.
Sure.
No, we do actually. It's quite common for us to have dashboards that literally look at these statistics daily, and from the senior leadership on down. And if there's something, flashing red, if you will, readmission rates are etching above 5%. Is an amazing number. We're usually at a 15% rate, if you will. If we're etching up 2% above that, that's a big problem for us on multiple millions of lives. It doesn't take much to get out of your cost of care budget. So acuity of care, closing gaps quickly, finding some way for someone to be out of a high expensive facility into a less expensive, maybe not less quality, but less expensive acuity would be ideal. And then for them to not have to go back at all would be nirvana for us. So it is a challenge. We're required to sort of put the price out annually, right? Our insurance products, we price them once a year. Think about that. Think about your job. If you just got to do your pricing once a year, and then statutorily you weren't allowed to change it, even if, say, a pandemic comes around, right? That's some things that you maybe not forecast. So you really have to, in the middle of that 12-month period, when you set your price, the only thing you can do is close gaps, improve care, or reduce care. So those are the things that payers will pay attention to. But they're like goldfish. Every 12 months, they forget everything they did previously, or at least the actuaries make you do that. So it's always constantly about turning over, finding new opportunities, closing more gaps, if you will. It's an endless fight, grind.
Yeah. So Dave had mentioned the importance of having auditable and traceable data, and I've heard that term used a number of times this week, auditable, traceable, as it relates to the AI. If you're going to provide clinical outcomes that people are going to make decisions on, it better be auditable, it better be traceable. Are the payers ready and prepared to understand what auditable and traceable looks like in this new frontier of AI?
That kicker at the end was actually, that's special. Because we're used to being audited. We're used to being sort of traced, if you will. I think Dave said a really important word, and it's probably not elevated enough. It's sort of trust. Because at the end of the day, I did cost of care. I was the per member per month. If you've never heard of that, that's a really important measurement that payers use. That was my job, to make sure that we hit our per member per month. And every time I put down some sort of project somebody probably else was doing, it was my name at the end of that, and it said how many PM we're going to save. And then the actuaries would come and talk to me every week, make sure we're tracking towards that. So I had to trust internally that my partners were going to deliver on programs. It gets even more challenging when I give that trust out to an external vendor. We will put you through a full colonoscopy before I trust you, because I have to make sure you deliver. There's no not hitting your target when it comes to cost of care. It's like owing money to the mob. They will come find you in that big building you're working in, and they'll make you explain why you missed and then how you're going to close that gap. And last thing I want to do is say I picked a vendor that did a poor job. That's really poor reflection on me. So auditability, traceability, diagnostics of how well you're doing and if you can do it better, truly important for me from a building that trust, maintaining that trust. So it's more of a trust and verify, but trust is super important in that process.
Right, great. Stephen, the word, everyone's been using the word trust, and your population in particular has been very distrusting of the healthcare system historically. How have you been using technology to build that trust, to really, not just with your patients, but also with Medicaid?
Yeah, I'd say going in with the mindset that this population is highly distrustful, understandably, of the existing healthcare system, and that if you deploy this model in a way that perpetuates that distrust, you lose them. I mean, yeah, thank you. Thanks, Juan. I'd say the secret sauce for Cityblock's model is engagement. It is what we pride ourselves on, is that ability to meet people where they are, identify what actually they care about, and then be able to best serve them using the care staff that we have across our markets. I think as much as AI can be used to identify those gaps and then triage them to that person on our team to be able to support them with probably not a healthcare gap in the very beginning. It might be food insecurity, it might be housing, but as long as it can be used to basically supplement the work that we've already been doing for a number of years, as opposed to perpetuating this idea that the system is against them, the more beneficial it's going to be.
Do you all work with private payers at all?
As in, like, do we contract with the?
Yeah, beyond Medicare.
Yeah, we contract with national, regional plans for their Medicaid and dual populations.
So what do you see as the differences? The questions that they're asking that are different from the commercial plans, like Medicaid and the commercial plans. Are they asking the same questions of you, the same requirements of you, or are they different standards?
Can't speak to the commercial side, but I'd say, just anchoring back to the point I made before, as much as we can engage that population to the start, like that is a huge leading indicator for us. Even if we're just starting to serve a new population, like we are looking at those engagement rates immediately to identify that as a leading indicator for ultimately how we'll be able to impact that downstream total cost of care.
Great. Dave, how do you all look at when you're engaging with a new client and you're talking to them about what success looks like? Where does enrollment and engagement fall into that process?
Yeah, so Rich, inherently our patient population, which tends to be Medicare-aged folks, is a little bit hesitant around the use of technology, but engagement is still around building trust with that patient or their caregiver or their healthcare proxy, and kind of trying to tie this back to the use of technology, and I think I said this before, is kind of surfacing the insights that allow us to have a productive conversation with whoever it is that we're speaking to on the other end of the line, and what that's going to mean for those folks moving forward. Sometimes it's little things with engagement, right? So once a patient enrolls in our program, maybe their oven's broken in their home and they haven't been able to get it fixed, or they couldn't get a ride to a practice for an appointment, or they're not sure what to eat because they can't afford to buy certain food. So kind of helping them through that process is going to drive engagement, it's going to build trust, and you're going to become an extension of the provider network within those patient populations. And that's what the providers need, because we can't extend or they can't extend themselves beyond the four walls of their practice. They can't intervene with a patient when they don't necessarily know what's going on or have that constant communication that we could potentially have with them. So that's where the value and the engagement comes in, Rich.
Great, thanks. And Joe, from the payer side, those clinical improvements and approaches that Dave's describing, do those actually show up in the data that you care about?
I don't think the data that we look at consistently gives us the right picture of a patient. We'll look at claims data, surprisingly, and the coding there are really hard. It's, you're not digits, right? We're people, and it usually is very hyper-specific to a condition or to a part of the person, but not generally the holistic view. So I think a payer is really poorly positioned to articulate that they understand the patient and they understand what's going on in that person's life. In fact, I think social determinants of health, sort of what you alluded to, was a big catchphrase probably 5 years ago, and it's no longer really in the vernacular as much, because I think payers recognize they don't have that ability. Yes, we've built some ramps for people in their houses and things of that nature, and we've given them access to high quality food at times through voucher programs, things of that nature, but we generally aren't there. We're not that hub. And I think that's why technology and vendors that bring technology to the fore are probably very well positioned to actually do that work on our behalf. And we can just do what we do appropriately, is pay. But again, there's a lot of trust, there's a lot of understanding, it's got to be very quantifiable. I was a part of an innovation lab at one of my prior insurance companies. We actually did statistically powered, publishable studies to prove that we would do this intervention versus that intervention. And so there's a lot of credibility that has to go into what you say you're going to do and how you're going to do it. And it's not just me, Joe Honcz has to believe you. I have to then get everybody else around me, every actuary, underwriter, P&L owner. It's a large undertaking and a large business case. So it's very challenging. In some ways, I think Dave hit the mark in that extending the hand of the physician and the support of the physician is probably one of the best ways to sort of move into this space effectively. And if you can align it to risk-based environments, ACO or at-risk or two-sided risk, I think there's a huge upside for technology that can engage the patient effectively. And the payer will pay for that. That's something they're interested in because they've reinsured themselves more or less, right? The two-sided risk, upside, downside. So hopefully that gave you a little bit of an answer that summing it all up, we really don't know what patients look like, which is their claims.
Yeah, I think we were having a conversation earlier about real world data, and it seems that it's like that seems far off in healthcare, but that seems like a stepping stone, right? Where it is that first step is extending the hand beyond the four walls, supporting them, but all of that data that I'm sure Stephen and Dave work with and their teams work with on a daily basis. Was the oven broke? Was are they food insecure? Are they housing insecure? Like that's the real world data that does over time will turn into insights and therefore our ability to manage outcomes better. So why don't we talk a little bit more about technology? So I think Stephen, we'll start with you. So what does the engagement the AI specific engagement model look like at Cityblock right now?
Yeah, so Cityblock, it starts from the time the member's enrolled. So we have agentic AI outreach that proactively identifies the member and then engages them to determine what their core needs are. Things I talked about before, whether it's food insecurity or housing or whatever it may be. They then work to then triage that to a member of our care team, at which point the AI then supports the care team member in essentially automating all of the stuff that doctors talk about all the time of not wanting to do, right? It's the clinical documentation, it's the note taking, it's sometimes something as extraordinary as like being able to translate a Spanish-speaking patient's words into English so that that patient can actually engage with them, or that care team member can actually engage with them. And then it's continuing to monitor that member's health, work to ensure that they are, I'd say, within our care team workflows in a way that is most suitable for their care and for our ability to manage the total cost of care of the entire population. Oftentimes, value-based care providers have stratified the risk of members largely in 3 or 4 tiers. I think AI makes it a lot more feasible to be able to get down to that additional level of granularity, to be able to take that social determinants of health data, take that claims data, and then be able to identify that next best action for the member as we think about engaging them across their entire care journey.
Yeah, I think our platform is very similar to what Stephen had described in that, in and of itself today, AI can't close a care gap, right? There's caregiver intervention that has to happen. There's a caregiver in the loop or a human in the loop, if you will. So, the ability of the technology to do the mundane work, to capture the documentation, to highlight different aspects of what needs to be taken care of so that we can drive efficiency with our care team. Just documentation alone, you can realize a 25-30% gain in efficiency because they're not taking that extra time at the end of an interaction to write up the documentation notes, right? So just kind of reviewing and approving those notes drives tremendous efficiency for our team and adds real value to what we do.
The only other thing I'd add is, to that point, we've seen some pretty incredible use cases as it pertains to inbounds. So we've used it as a mechanism to take on some incoming member calls to facilitate that triage. Listening to some of the recordings, it's honestly pretty extraordinary. The compassion and patience that the model is able to leverage with the member, like, it's amazing. And you have members that have many, many needs that ultimately we're able to get them that level of care within minutes, despite the fact that initially, like, they might have been, let's say, averse to working with us at all. And I think, like, that, listening to some of those recordings, I think it's a whole new level from, like, the chatbots that we're used to. And that's something I'm really excited to see scale. Because let's be honest, like, sometimes you're receiving calls from whoever it may be, and you might not have that patience. You might not be able to take that compassion. And it's kind of always able to. And that's pretty amazing.
You know, what I've been surprised at is the sophistication of the telephony specific to HIPAA-related companies like ours, or companies that have to meet that HIPAA requirement, and the QA plugins. So it's QAing the conversations in real time, and whispering, has the ability to whisper in the ear of the clinicians to help them guide the conversation. And the one point I do want to make is, as much as it's really important, or helping us not only stratify, engage, build trust, it's reducing the level of pressure on the clinicians themselves. This is a high burnout job, unfortunately. So anything that we do that can decrease that, you know, they're dealing with the emotions. They're taking on the amount of emotional stress they're taking on in some of these calls is immense. So to be able to reduce that burden reduces the turnover, makes them happier at what they do. And what we say internally is we want our clinicians operating at the top of their license, right? We do not want them swivel chairing between 3 different systems. We don't want them having to extract data from PDFs and input it a second or third time while they are listening to listening to the patients and trying to identify the next steps. So I think that's another area where, you know, AI is having a big impact, and behind the scenes for companies that are operating, that's a huge expense, right? That's labor is our largest expense. So being able to not only manage that expense, but have happier, healthier employees is going to be what I think one of the most positive impacts to the business models in the next 5 or 6 years. Great. So maybe we can move on to AI. A couple of questions. AI today, AI tomorrow. What's real versus what's coming? So we'll do this pretty quick. But from each of you, what is one thing AI is doing really well? So be specific as you can in population health. That you stake your reputation on, stake your claims on, and one thing it's not ready for yet.
Yeah, I can start us off. It's what you just spoke to, right? It's being able to take on a lot of that manual work that the physician is taking on today, ambient listening, clinical documentation, everything like that. It is not ready to actually make the decisions as it relates to what the member needs from a patient care perspective. I just don't think we're there yet. Maybe we will be at a certain point, but right now, like, the human in the loop is still critically important.
Yeah, totally agree with that. AI and technology does a couple things really well, right? It finds signal in the noise, provides the information, works within our workflows. We're an existing business, so we use that technology every day to drive outcomes and work within our existing workflows. And then the other thing that does really well is it gives the provider the information that they need to make a decision. It's just not ready yet, to Stephen's point, to do it itself.
Luckily, I have a poor reputation because I don't know if I should stake it on this, but I did call a friend of mine who's still at a large payer in Connecticut, just to ask him how they're deploying it. And there's a couple things I just highlight. One, I did a panel at the Academy of Managed Care Pharmacy a couple years ago now, and had the chief AI officer on from Anthem or Elevance, and his big claim to fame at that point was that he had deployed Copilot to all 40,000 employees at Elevance, which I thought was pretty amazing because, first of all, it's a little dangerous, right? They have their own instance, so they can contain it. But more importantly, he said 50% of that 40,000 were using it daily. And their executives were using it consistently and pinging him constantly about why can't it do math? That was a couple years ago. You can do math now, but they were using it to analyze spreadsheets on cost of care. So from an inside of a payer's perspective, one, it's improving their ability to be administratively efficient. These are big, lumbering organizations. The more efficient they get, it's really kind of critical. On a micro level, talking with Chris, he said, and I'll sum it up very shortly, it's becoming more brilliant at the basics. It's sort of the things that we've talked about here is, one, I know who the most critical patient is. Two, I know what the most highest priority gap closure I need or issue I have to close with this patient. And two, I have the intervention at hand or I don't. And I don't waste a single phone call or a single outreach. So I think those are two macros I would talk about. Maybe I put my reputation on it, I guess.
Yeah.
All right.
Great, thanks. Next question. So the data, right? Junk in, junk out. And I think there's still, there are a lot of different players in the space. We have EHRs, we have claims platforms, RPM platforms, behavioral signals. Now we have real world data we're collecting. We do have standards, industry standards, data structures, but ultimately whose responsibility is it for solving that problem, right? To structure that data and make a final determination and move forward. Is it the technology companies, or we have to wait for a technology company to get out ahead of that and be big enough to make a change? Is it an insurance company, or is it Epic?
It's an epic request. So a couple weeks ago, I was at ISPOR. I don't know if people are familiar. It's an outcomes research, mostly focused on pharma. But CBS was there with their Hofbauer organization. I don't know if you've helped. Okay, some head nods. Some good people there I used to work with, really like them. But they are trying to create that registry effect and do the good, deep work possible. I'm a skeptic, generally speaking, because I've been inside the walls there, but there are some really smart people there. So I think there are large Fortune 5 companies trying to be better at this. I'm just hoping we don't ever have to structure data again, and we can work in a normal way of just info, whether good or bad. We can come to some conclusions maybe through the analysis. But I would say there are some large players trying to figure that out. Again, trying to monetize it at the same time, right? So there's a little bit of a give and take there.
You know, I would, at the risk of sounding a little vanilla here, I would say it's a shared responsibility, right? But shared to the point where there still needs to be some ownership and accountability. So at the end of the day, is the provider getting the information that they need to get the outcome that they're looking for? And is that information being passed along? So if that isn't kind of the end goal in terms of kind of shared ownership, then I don't know what is.
Who does it? I don't know. It's going to be government enabled, but I think who is incentivized to do it is whoever bears the risk. And that's the big thing, that whether it's a value-based care provider like ours, whether it's the payer, they are heavily incentivized to make sure that the data is such that they can effectively manage the total cost of care of that population. And whether they build that functionality internally or whether a technology company is able to support us or them with that work, I think is to be seen. But they're the ones that are probably going to drive the innovation, in my mind, especially for the federal programs.
Yeah, I think I agree with that as well. I think it's the technology's responsibility or the tech community's responsibility to continue to push the old guard, so to speak, push their systems, show them what's possible. Sometimes you need to go in and show enterprises who have been operating for 30, 40, 50 years what's possible. You will run into, those of you who are, are startups or trying to land your first, second, fifth, 10th customer, even, for Alopex still trying to land customers, convince them that our data is cleaner, better, and is going to produce better outcomes than what they've seen before. That responsibility does lie on us. And I think we've seen this pattern through technology over the last 25 years where there will be some bright spots in the technology ecosystem where someone's data is obviously clearly better than others. Google Maps versus Apple Maps, right? Like it's one of those scenarios where somebody got it right, they structured it properly, they were thoughtful, they did not let their guard down, they made sure that data was going to continue to improve, and then you had another product that was just trying to compete for eyeballs. So. All right, well, right before we open it up to questions, lightning round, if you could change one thing about the way healthcare system approaches population health, what would it be?
Not sure if it's a change, but I'll say an imperative. Don't wait for the innovation to trickle down to Medicaid. Build for Medicaid initially. I think there's a large sentiment that we'll start with commercial population, and then ultimately it'll flow through. I think social determinants of health might not be the buzz phrase that it may have been 5 years ago, but building a tool with that data integrated into it is so crucial to be able to build one that's effective to serve the Medicaid and dual population that we work with every day.
I would say that it needs to become more proactive with the technology and the data. What have we changed through the use of technology? What outcomes have we improved? How has that patient's life gotten better because we've been able to intervene more quickly, get all the information that's required to produce the best outcome that's possible for that particular patient or that particular population? More than the reactive, mode that we've been in for the last 50 years with healthcare.
Good question. I was trying to think, I think changing the frame, the lens, when you say pop health, it just seems too impersonal, too big. I guess I like to change the lens in the context of it's patient health or person health, and that's all so individualized. Back in the innovation lab, we were talking about how can we leverage things like Alexa that you have formed a relationship with to become your sort of independent advisor on things of health, if you will, when it's empowered properly. I mean, who do you ask for referrals when you want to go see someone, when you need a cardiologist or a GI person or a respiratory? You ask your friends and your family half the time, which drives me crazy as a payer and a pharmacist, because that makes no sense, but it's what happens, right? So let's try to flow with the way life actually works and leverage the passiveness of the things that are in our life to incrementally change. I guess that's where I'd like us to start or be at some point. I mean, you're wearing a sensor today, and you've got a watch that can actually see your heart rhythm on it, but it probably doesn't tell you all the things that it can possibly do for you passively along with your life. I think that's where I'm fascinated.
Yeah, I would add that I think you're all, the theme here is that real world data theme, right? These sensors on my wrists are real world data. How do I get these matched to my healthcare record? How do I, as a patient, how about patient in the loop? How do I have access to my data where I can correct my data when I see there are errors? I had a recent, echocardiogram of my heart, and got the findings back, opened up my Epic chart, everything looked great except the last one. And it was so far off that it was clearly like a mistake, like somebody had, entered the information wrong. Flagged it, they didn't do anything about it. I ran it through Claude. Claude told me what probably happened and actually said probably somebody fat fingered it, put it in wrong. But how can I get in there and make that adjustment and flag that? Because now it's just there, right? And NYU, sorry. Epic, whoever. So I think the real world data, matching that up and having our data, we're consumers. We use all sorts of other tools in our finance, in our healthcare. We're all using all sorts of interesting tools in healthcare, but they're not connected to our patient record, our master record that our primary and our specialists know. So that's what I'd like to see. So with that, I'd like to thank you all, and then now we'll open up the questions, and you were first.
Sorry. Great panel, and obviously like one of the top 10 things needed in healthcare right now, right? But here's my question around shared risk and aligned incentives. So as you're hiring folks, you're taking risk, right? Like you fail and your margins hurt and your investors are pissed. For the people who are supporting you and for you all as you do contracting, how are you managing sort of shared incentives and shared risk in this population and managing it even from a cash flow basis as companies, right?
There's a myriad of ways which you can structure a relationship from that perspective. A lot of it coming down to targets that you shoot at. For my preference when I did this kind of contracting work would be to, one, start with the intervention and just work my way through like what I can expect from it and what I can believe in it. You can't have any outcomes unless you have engagement. So that was a major measurement and sort of a gate. Like if you don't get a certain level of engagement, nothing else matters in this contract, and we're not liable for any sort of payments. And then there's sort of kicker approaches where you hit certain milestones or massive improvements. Then I can share the savings, if you will. That model where everyone sort of sits on the same side versus just pure bonus potential or per member per month target. Something that is a bit more collaborative in that we can be iterative in your intervention. So let's solve for something and then figure out if we can take that sort of similar approach and iterate on another problem. Because I have a laundry list of problems as a payer. It's endless. It's a spreadsheet, and you just keep going. So I think those are the different sort of structures. But at the end of the day, unless you have to get engagement, and then we can hopefully share in the savings of that, and that keeps us tied to each other pretty tightly.
I don't know how in the contracting weeds we want to get, but generally from like a cash flow perspective, we'll take a provider fee up front, and then that'll be reconciled as MedX as we think about our MLR target. We'll also have quality bonuses that we may be able to impact that will improve our positioning. I'd say from like a population health standpoint, we might get a list of 50,000 members during initial underwriting. We will then work with our actuary team to determine of this population who are those that we think our model can most uniquely impact and actually drive support for. And then it's a back and forth with the plan at that point to determine what that population ultimately looks like.
I'll just add this, having executed a number of risk and value-based agreements, if you've seen one agreement, you've seen one agreement. So there's so much nuance to these risk-based agreements that they're all different.
Hello, what a great topic. And so I'm Tinja, rhymes with ninja. I'm a payer, provider, physician, health exec. Used to work at Hopkins and transitions of care, now at a payer provider's primary care, elder living. But in all of those worlds, you talk about the doctors, about the trust, about the tech stack. I would love to give my doctors what you're describing, this front-end interview style, but all of that information lives in one vendor program, but then the EMR is in a different vendor program, and for it to really affect change, like all those things have to talk to each other. And so do you foresee, is it Epic that comes in and says like, well, we have it all? Or from my vantage point, I'm bombarded by vendors and like, what is the best? Everyone says they have the best thing, and everything says they connect to everyone. So, like, what's your hot take on what's going to happen, or is it going to consolidate, or how do you bring that front end AI customer discovery, really? Because what matters to the patient is what will allow me to change behavior, decrease expenses, have that goals of care, the whole spectrum. So, yeah, could you comment on that?
Sure. I would say, from my perspective, I think what we find, and there's parallels to other businesses as well, not just healthcare. So we go to you and say, hey, we're going to collect all this data and we're going to give it back to you, and you're going to have all the outcomes you need to, prove that you're doing a much better on behalf of your patients, you're saving money, et cetera. You don't have that ability because, great, I give you the data, what do you do with it, right? Because you have this huge ecosystem. So this is where the technologists have to take the lead. So in the background, a lot of the work, a lot of the things we're thinking about, how do we make sure we have the dashboards for you? We have to give you not just the data, we have to do the analysis, we have to give you the outcomes, we have to give you the dashboards in a way that's easy for you to digest, easy for your tech team to digest, easy for your executive team to digest. It's a lot to ask, but I think any tech company that's getting into, into healthcare, they have to understand that's what's going to happen, right? You are going to get sucked into your needs in a very deep way. You're not going to solve it from the inside out of a huge hospital system or a huge health care system. I personally don't think that, because that is a decade-long change. Technology is changing too fast for that.
Hi. I think one thing we've talked about is the number of tools and softwares and measuring things that are passive. Like I have a Whoop right now I got as a gift. I have a Garmin. I have a Function Health. And each of these are starting to try to give me recommendations. And so as providers who are trying to manage chronic care, do you have any thoughts or strategies on how you'd reconcile, I don't want to say competing recommendations, right? Like there's certain diseases have tried and true methods, but if one tool is telling me to rest because my heart rate's too elevated, and the other one says, no, actually you should go for a walk, and then the other one, how would you manage that kind of information when it may not be coming through you? So I guess information overload from the patient perspective, where everything's going on engagement, but not necessarily through your platform.
In my opinion, it's more about getting the information to the provider rather than making recommendations at this point. So I've worked with platforms before that reference clinically acceptable standards of care and different things to highlight for the provider. But at the end of the day, I think it's more important that the provider gets the information so that they can make the recommendation that they need, which they feel is best for that particular patient, if that helps.
I think it's kind of to what your point was previously, and like the data aggregation in a centralized system that can then be continuously analyzed to determine what are the appropriate, like what are the relevant signals and what are not what are the signals that are irrelevant, is going to be critical. I'm not going to speak to it as much from a provider lens, but I think as we think about managing total cost of care for a broader population, like risk stratification is probably the equivalent at a population health level. And we envision that a lot of the data that we have, not only through EHR and through claims, but also the patient-specific Medicaid and duals population data that we've gotten from years of engagement, is going to be highly relevant for being able to adequately engage and serve that population.
Yeah. One thing I'll add just on those, my opinion regarding those platforms like Whoop, and Apple has more data than like anybody, is they're going to have to do the studies, they're going to have to publish the papers, they're going to have to come up. My opinion is, and I think Whoop and Function, they're on the path, they're going to come up with studies, they're going to have enough data, they're going to be able to publish, and at some point that will have to be recognized by clinicians as a, something that's worthwhile. Instead of, I'm sure you get handed like, here's my ChatGPT like output, but if it's, I've shown my physician my Whoop data and they roll their eyes. So, but if there's a point where the Whoop data says, okay, here's a trend, this is worth looking at, and they've published and they can convince clinicians, then they'll look at it, and then that's when it becomes more more valuable. So I think it's and I think Whoop and Function and Apple all know that, right? Some will stay away from it. It seems to me, Whoop was here this week. I'm sure there's plenty of people they're probably sharing some of this, but it seems to me they're headed in that direction. They're doing studies. They have all the data. It's accumulating fast, so hopefully it will come soon.
One other point, I think we're framing this from the reactive lens, like patient brings this data to provider. I think it's really exciting how this data can be used from a more proactive management standpoint. Like doctor has this data available to them. They see that the wearable data has spiked in the last 24 hours. That then can be used to proactively engage that member. And that's something I don't think we're doing today, but like that is something I think we're going to see in a few years, and I'm excited for it.
Thank you. You know what, I noticed the question in the front were really around, coming from the healthcare provider side, and how do you evaluate through maybe an RFP comparing different vendors. Perhaps I know a lot of the folks here are actually on the other side of it, the healthcare tech startups and the actual founders. Are there any tips or advice you can have for those founders, those startups, and how can they win the hearts of the healthcare, companies, and actually the, health systems, for them to win the RFP and be the ones that are selected to kind of beat the other competition that's out there in order to get those maybe initial pilots or just larger contracts?
Here, Joe. Yeah. First of all, kudos to you if you're one of those people, because this is a bag of pain that you're going to be carrying for a long time. You can't be everything, because then you're nothing, but you can't only be a one-point solution. So that's where I always struggled when I vetted a vendor. If you're hyper-focused, that's great, but again, that misses the bigger picture. If you're then the opposite direction, it always probably starts at best as being very, very clear on what the unmet need is and what does that patient look like that you're now going to engage. Without that clear picture, and then the unmet need could be the fact that there's no standard of care, or that the standard of care is purely anecdotal at this point, or that it's a inadequate response, intervention, if you will. But if you can't tell me clearly what that unmet need is in literally 10 seconds, you're done, you're cooked. I'll listen, I'll be polite, but I won't probably ever talk to you again. Or I would have been wasting your time. So unmet need, and then who the patient is, because if it's every patient, then again, it's nothing. It has to be well defined. And you have to say how you can then engage them. How can you show me that you can deploy the intervention, and how that patient journey cascades, if you will. But you can't get me there unless you tell me what the unmet need is.
I'll add to that, saying, being the commercial guy in the room, it's all about outcomes, right? And one of the hardest things to balance is when you're a startup is making the investment to do a pilot with somebody, knowing that there's not any revenue yet on the other side, right? And getting your investors comfortable with that. But if you don't have the ability to walk into these discussions with significant outcomes that can be driven by your platform, you're probably not going to win.
I used to work at a Noble Care, an at-home primary care and accountable care organization for seniors. And one thing that really helped us reduce hospitalizations was our care coordination model, where in between visits, care coordinators are calling patients. And then one thing you said that stood out to me, Stephen, is voice AI agents. They're getting better by the day. In 6 months, I don't think we'll be able to tell if they're separate from humans. Well, how do you see voice AI agents augmenting the care coordination model, where care coordinators are calling patients to make sure they're taking their medication, eating the right foods, any questions about their health plans? That's something an agent can do. And how does that change the billing structure when we look at a fee-for-service perspective, where
There's no billing structure for that. To my knowledge, there's no billing structure for that. You'd have to take a capitated approach or a total cost of care. But what you just said until the payment part was awesome, because I think that's truly getting back to humanistic care versus billing care. And until we get there, we really can't improve the outcomes. We can't report them. We can't measure them. We're not showing any sort of differences in changing over time. The billing can be done. Digital therapeutics sort of showed a way. There's different billing codes that have come into fruition over time, but that's a really hard road, because you're going to have to get the federal government to do something, which is challenging at times, or CMS. Although I would say this administration's been probably the most interesting, progressive, dynamic, you pick your word, but you might be a place now where there might be some receptivity to it, but capitated, that's probably it.
I think that it's extremely useful. I talked about it in terms of some of the use cases that Cityblock's using it for. That being said, I think that maintaining that human relationship, if it's already been established, is critically important in a lot of cases. if there is already that initial touch point between the member and the care provider, they have talked to that person about like things that are very challenging, and then they are then like funneled back to an agent or not able to reach that provider easily. I think there's risk of turning that member away, and maybe the agents will, and maybe as a population we will become more and more comfortable engaging with those agents, and this problem will be less relevant. But I do think maintaining that humanistic component is pretty critical, at least for the population we serve.
Yeah. I'll just say that I agree wholeheartedly. I think you need to have a clinician in the loop for the foreseeable future. I don't think the voice agents, they have the data structured in such a way where they remember the patient and like give them, like that's such a risky, very slippery slope right now. So I think we're a little bit away from that. You can have an agent whispering in a clinician's ear to help guide them if they're missing something, right? That's where I think it's starting. We'll see where it goes. We tested a sales agent, and it seemed amazing the first like 2 months. And then it starts hallucinating, and it's like scheduling meetings for like people that don't exist on our team to meet with executives. I mean, it gets out of hand pretty quickly. So, if I extrapolate that to like someone's healthcare, like it's not a good place. So I think we're a little bit out on that. But you're next.
Thank you. Thank you very much for the panel. My name is Vishal, and I'd love to know a little bit more about the user journey within your platforms. So chronic care conditions will be different per specific user, just trying to understand what the inputs are and how each specific chronic condition will be treated separately.
So our model, again, Medicare-aged folks is primarily who we're servicing today. As you well know, is based upon 2 chronic conditions, right? They're expected to last a lifetime. So, or until death, right? So in that vein, we have clinicians on staff that are specifically trained in metabolic conditions, so diabetes, heart failure, hypertension. We view chronic care management as that longitudinal relationship, and then as we develop a relationship with the patient, we work to determine what other remote patient monitoring devices we can bring into the relationship in order to get the outputs that we need. So, if it's a heart failure patient, we'll send them a cellular connected scale, or hypertensive patients get a cellular connected blood pressure cuff. So we use all of that data to collect the signals in order to drive the outcome and the relationship. But at the end of the day, it's really powered by CCM or PCM or some type of care management program. It's not RPM led. The data just has not been able to produce a sustainable outcome when you use just RPM, an RPM type solution. So did that answer your question?
Yeah, it does.
Okay.
Yeah, I'd say from our perspective, I think it's AI enablement of the existing care pathways that we've had for our populations for a long time. Premise behind them being, in every market, you have a different patient cohort. That patient cohort looks different. It might be BH, it might be heart failure, it might be pregnancy, and ultimately putting that patient on the clinically validated through the clinically validated programs in order to be able to improve their well-being and drive that clinical and financial impact. And then from an AI perspective, I think it's aggregating the data like we've talked about, and then ultimately enabling that physician to be with the member, because you've automated all of the other stuff that is not actually patient-facing.
Hey, Aaron with Palm State. We do agentic claims management, but I wanted to tie a couple pieces together and then ask a question related to it, because it just came in this context. So we were talking about the spreadsheet of all the different things that the payers have, and we were talking about the ROI related to specific conditions, and then we were talking about vendors having these data silos. So that world is going to continue to explode, and there is no solution to that problem based on what I've heard today, unless I'm interpreting things incorrectly. So what I'm hearing is actually another application of AI like in a snowflake layer or somewhere in the back, where you start having your agents communicate around what are the most important things, and then have a human in the loop in the back end before doing the chronic care management outside. Because if we have Apple Health, if we have these watches, if we have each of these pieces and all of those have defined data structures, like the innovations that we're seeing in like receipt management and claims management and all that stuff, then there's a layer potentially in the back from a in the technology space that you can coordinate and get in the front with before going out to your patients, where you have optimizations around the data that you're seeing, where you can sensically aggregate issues. Have you heard anyone talking about that? Because I'm just piecing some things together in the room for today, and I'm like, wow, these data silo problems are going to be impossible unless there's another way to solve them. So I'm just curious if you've heard anything like that.
No, I think there are a couple platforms that are in the background that I think are trying to connect aspects of it. So I don't recall the names of the platforms themselves, but I have seen it. So people are thinking about it. I have not heard the agentic approach to be listening across. Yeah, I have not run across anything like that, but it's one of those things that could be a great solution if it's elegant. Could be an absolute monster. It could be you might be creating another monster. Like that would be my only concern there.
Awesome. Could we give Stephen, Rich, Joe, and Dave a big round of applause?